Hello, everybody. Welcome back to another episode of PT Outcast. I'm here with your co-host Carly, and today we're joined with Sam Schmidt. So today we're going to be talking about primary care in physical therapy, and in specifically urgent care in physical therapy. And there's a few reasons that we're talking about that. There's been some changes that have happened legislatively in some states, which is interesting. There's just also inertia and momentum in this field. And Sam is doing some really spectacular stuff. And we became acquainted recently at the Graham sessions, and she was a delight. She was one of the panelists, and it was really wonderful. And so we made quick friends, and here she is to speak to us. So, Sam, welcome to PT Outcast, and I'd love it if you just tell everybody where you're from, what your roles are, give us a little background about Sam Schmidt.
Thank you. Thank you so much for having me. I live in Montana and most of my life, although I've left for education and other job opportunities, but I've always come home. And I am a private practice owner with some of my best friends. We have 6 clinics in Missoula, Montana. And I stepped into APTA Montana during COVID when things were going kind of sideways. And, I'm one that tells my kids they can complain about the problem once and then they have to do something about it. So I kind of followed my own advice there and got really involved with APTA Montana during that area. Became the chair of legislative committee as well as the vice president, and work hand in hand with Emily Hernan, who is also a big advocate out there at APTA nationally. And we just have a lot of fun, and we've gotten a lot of stuff done in Montana. I guess of recent, we were able to pass direct access for workman's comp, which specifically now allows the injured worker to come directly to physical therapy. And by statute, we are now recognized as treating physicians under the work comp
That's
laws
great.
in Montana.
Congratulations.
So, and we had 3 other bills that passed almost unanimously. So 4 bills in one session. We just have a great group of people and community really engaged in Montana right now, doing some awesome things to elevate the practice. So, and I've recently, my term kind of terminated with vice president of APTA, and I ended up still involved with the legislative chair, but now I'm co-chair nationally of the APTA Federal Primary Care PT SIG. So that's kind of another role that I'm playing.
Yeah, and just tell me a little bit about what that SIG does. I don't know, people might not know about that SIG because like federal section is not like the ortho section where there's 17 million members, right? The federal section is a little bit different. And you're like, well, I'm not federal. Why do I join this section? So this is one small bit of the federal section work. But tell me about that SIG. What is it? Is its mission?
Well, it's really to promote and educate and gather knowledge and research and practice patterns around this concept of physical therapists as primary care providers, as a first contact provider that the patient comes in to see. And while it is under the federal umbrella, we are seeing in the last couple of years it just exponentially growing because it's bringing in folks from private practice, obviously, like myself, but also home health. We have lots of folks that are like, well, I do that every day. Like I am doing
Yeah.
system analysis and referring for, diabetic footwear and all the things. And then, we are also seeing other folks, even from pelvic health, other SIGs and other sections. So it's been really fun to see it kind of spread. And I will say that talk about some awesome, smart, cool people that are driven to elevate this profession that really want to have fun doing it too. And I really look forward to our meetings. We have a great time, and they're just such stimulating folks just trying to really think about how this is coming along, because it's been slow and now it's kind of like a lot of things gradual to all of a sudden. So I think that there was a lot of work beforehand, but now we're really in this cycle where it's kind of taking off.
That's great. Carly and I were having a conversation at Graham Sessions as part of the panel about primary care. It was a definition that had been made, and it tried to define what is primary care. And Carly and I were having this debate about like we didn't really know how to define it, right? So um, I like this idea of first contact. That kind of like helps me streamline it a little bit. Are those terms interchangeable, primary care and first contact, or no? Or they're slightly different?
That's a great question. I think we have to really think about who our audience is when we're talking. I think first and foremost, PTs need to understand all of the audience so we can really use those terms depending on who we are talking to. But I think that most folks, when you say first contact, that does kind of help build the bridge to what that means. I think probably payers and healthcare systems, policymakers kind of know more primary care because that's the infrastructure of our healthcare system in the US. Um, and so I think first and foremost, you have to think about who your audience is. But I kind of like the idea of that first contact, the person that's coming in that may not have seen a provider for this condition, or like I've had somebody that hadn't seen a doctor in 31 years come into my walk-in clinic. I also think of myself as a primary care provider as a quarterback. Like that person's
Mm.
coming to me and I am going to help them navigate the healthcare system in the most efficient way and really kind of say, like, this is what I can really help you with and help streamline this process, but we need to expand your care team for these other elements. And that's fun. And so that's kind of how I kind of talk about it in loose terms.
I love that. And you mentioned something just now, Sam. You mentioned your walk in clinic. And this is something that I think is maybe starting to grow a little bit in physical therapy, but definitely is not quite at the same level as the way we think of being a first contact or primary care provider previously. Can you talk about that, like the walk in clinic and what that is exactly? Because it's so cool. You blew my mind at Graham Sessions with this. I was like, what? So, yeah.
Yeah, it's been 8 years in the making. And it kind of came from a lot of different drivers, but my business partners and I are kind of pain science geeks. We really are passionate about addressing persistent chronic pain. And it became kind of one of those cocktail discussions where we're like, how can we really address this and really make an impact in Montana and change this? We're like, well, what if we were able to see chronic pain before it became chronic pain? Like we actually were able to educate people what is pain, what drives pain, what are the pillars of pain influencers, and really explain pain in ways that patients could then navigate the system in a way with that information instead of catastrophizing and being over medicalized and then delays and unnecessary disability. Like what if it came from that what if? And then, also from our own experiences, we all love to play in Montana. You're mountain biking, you're skiing, you're, playing hockey. You're falling a lot and you're getting injured a lot. And, it was like we were always coming in and treating each other. And we have small children, kind of like you, Carly. It's like, how do you fit in PT when you have to book out twice a week? And all the clinics around Missoula, people in Missoula are high users of PT, which is great. It's kind of that Starbucks effect. There's really good PT here. And so, but it's hard to get into, and sometimes you don't need like a lot of visits. So then between those two things, we kind of became this concept of like, let's start a walk-in clinic. And we started it kind of as like in this broom like broom closet down the hallway from one of our clinics, and we kept it as a separate business. So it was cash only, just because insurance, in case you guys aren't aware of it, is really complex and sometimes hard to navigate, and like getting authorizations right away and who has what. So we just said cash, it's a separate business. And then we contracted our PTs from Alpine, our mothership big company. And so those PTs work for this other company. And we did cash walk-in in this broom closet. It took off. People were starting to get really like familiar with the model in Missoula. And so then we decided to go bigger. We went out and did a brick and mortar and 3 treatment rooms. And that construction was done. And we had our grand opening March 2020, which
Oh no.
is exactly when everything closed down, right? So little hiccup there. But then, of course, we pivoted and like all things, it all worked out with some good work and innovation and adaptation. And we got it rolling again. And that even included kind of some of us working on the set of Yellowstone, just trying to, because they needed PTs on the set. And so we were kind of trying to do it all concierge and a little bit of the walk-in. And it was great. But what we found after pre 4 or 5 years of running the walk-in cash, the highest users are people that know PT, right? That have really good insurance. And so they wanted to use their insurance. They've had success with PT in the past. And then it's a bit clunky, right? Because you're not in this, we didn't have even a receptionist. Everything was online. We didn't have any support staff working in this. We were kind of bare bones in the cash model. And so you couldn't trying to communicate to other offices and make referrals. And so that became a little bit more clunky. And so then we decided to kind of really pivot and say, like, could we do the walk-in model under the traditional outpatient? So then we went in Alpine Physical Therapy, then opened a very small clinic room inside actually an independent imaging center, sports medicine center, where there's other providers that besides the imaging center that are independent, all working in the same building. And so we had a walk-in model there under Alpine. And then we just had to like try to change and figure out who gets to come into the walk-in insurance wise, which insurances need prior auth, how do you do the copay? And so then it's just kind of like, I literally was flying the plane and building it. Like, and again, I just feel so fortunate. Most of the adventures I've been on in my life, whether professional or otherwise, I have amazing people that are okay with like falling and getting back up, and we all laugh together, and we actually continue to make it better and better. And I think like that's how we learn, that's how we adapt. And so we just kept building the plane. It's like, oh, we need a wing over here. And we got it to the point where, it was working pretty smooth. And at that point, then Alpine ended up kind of taking over the cash model, and we brought everything in-house. And now we have 2 walk-in clinics that are kind of standalone. And it's been, trying to navigate the staffing of that. And yeah, again, what we've used for our company is a lot of the more experienced PTs and or PTs that are either managers or have potentially programs that they oversee. They walk in, they do a lot of the walk-in hours, because if it's slow, then they'll have some other admin stuff that they could be working on. And I think, things have just evolved to continue to support that. So, and in Montana, we've had direct access, or we've been like kind of that first contact provider since 1987. And just because of the ruralness of Montana, even though Missoula is a big urban hub, people identify, sometimes you have these towns that only have a chiropractor and a PT. So that's where people are going to see. And we've been really had the fortunate landscape to practice at the top of our scope. So it's never been like this question, especially as we went to the legislation and talked about direct access for the injured worker. It passed unanimously. Like it was like a no-brainer. So it was great. So that's kind of where we are now.
So these walk-in clinics, you talk about them as walk-in clinics, or also urgent care, PT urgent care?
Yeah. It's, it's funny. We go back and forth. Like, what do we call it? Originally it was called Physiotrek because we couldn't land on anything. So I think, I talked to different private practice owners. They are like, well, we kind of do that. We have same day services, or same day appointments, or, if someone's been a a patient of ours on and off over the years. We always squeeze them in on the lunch hour, stay late, or come in early. I'm like, so you have urgent care hours? And they're like, well, no, we don't. I'm like, sounds like it. Like someone needs help. And so I think, again, it comes back to language. We know this in pain science, like language matters. And I think that, like, I think part of it is maybe fear. Like, can we name that there? And like, what will we get if we do name it that? Will the consumer know? And interesting, like in the medical model, urgent care was actually introduced in 1970. But it wasn't until like the late 90s, the early 2000s that we actually saw urgent cares. Because otherwise it was just like ER or you wait and see your primary care family doc. And so, and now like as a mom, like if I'm looking at my son, I'm like, am I going to the ER or I'm going to the emergency care, urgent care? And I kind of know pretty quickly where I'm going to go. And so in the time that I've had folks come into the walk-in / urgent care, they've all been, I've never had anybody that's been like, oh, you need to go now to the ER. But interestingly enough, when I have practices in like my traditional clinic, I'll have patients come in and, I have sent people
they
to
need
the
to
ER.
go. Yeah.
We need to
Like,
go.
yes, and driven them and, that sort of thing. So,
Yep.
and I think a lot of rural PTs that I've talked to across the state of Montana, like nod their head and like, oh yeah, Ethel, she'd always come out. I'm like, no, Ethel, let's get in the car. You're going to the ER. Like, well, I didn't want to bother. I don't like going to the hospital unless
Ethel
I
never
need
wants to bother anybody. No.
So yeah.
What diagnoses do you see in these walk-in clinics? Who are the people that come in?
I mean, so we've essentially, like, I'm a glorified scheduler in some ways, or a nurse navigator in some ways. Like someone comes in and I evaluate them, and they're either going to fit that spot where it's they definitely need to have more traditional PT. They need some consistency here to get out of that rut or a longer term, and that's where I may refer them into what we call our traditional models at one of our other clinics. There may be somebody that is a high user of PT and they have all their programs and they were out, they had a tennis tournament and they just need some, a tune up on what exercises should get this calmed down and maybe some dry needling or something like that. And they might be busy. So they may come back in a week or two and they get to decide, and they'll book that appointment. And then the third one is somebody that maybe needs a little bit more management, where I may be seeing them, but then I'm like, okay, we're going to establish you don't have a primary care doctor. Let's figure out how we can get you one of those. We're going to order some imaging. Let's get you in with the pelvic health PT, like, where you are taking more of a role of like navigating them and they need more than what you can offer. And of course, we have those folks too that, like I was telling Carly, like, yeah, this is shingles, and I'm going to need to refer you to a primary care for pharmaceutical intervention. So, oh no, I'm too young for shingles. No, this is definitely shingles. So, I think a high use of low back and neck pain, which I think we all have either experienced ourselves or seen family members. Yeah, I woke up, I don't know what I did, or I bent over, I don't know what I did. And those are like make me so happy because that's where I really do feel like I'm really impacting the healthcare system and reduce costs and reduce persistent pain and unnecessary disability. When I can like really prove to somebody like your neuro screen is great. It looks really solid. We don't have any concerns there. Listen, if we give you different cues here for your muscles and the tone reduction goes down, look at you can move without pain. Those muscles are protecting us and that's good right now. But we need to restore normal mobility and range of motion. And these are the pillars of pain. And so I want you to think about like cognitively and social and like the physical and how are we going to manage that? That is like what I love to see. And I think we see a lot of that, the spine. And so that's probably, and then, the acute sports and all that too, twisted ankle or people that are about to go on to get at this a lot. I have this really expensive trip I'm supposed to go on. Should I go on it? Or I train for this like competition. Should I still do it? And so those are kind of fun some really fun evaluations too, because you get to help this person decide, like, yes, you could do this, kind of here's the pros and cons, and here are we looking at. And so,
Yeah.
yeah,
Okay, it's so great. And one thing that you said, I think, Sam, that it's been circling in my mind, and it continues to circle in my mind. You mentioned top of scope, right? And so I think when I think about people who are maybe not in a alignment that PTs are going to be capable or able to fulfill this role as a first contact provider or primary care provider, my first thought is, well, we already do this. We've already been doing this. It's just semantics, right? Different words. But then top of scope, I think that's a really important piece of like, how are we preparing our students? How are we talking about it with our students when we're educating? Are we preparing them to be ready to step in and start practicing top of scope? So, what are your thoughts when you are maybe working with a new therapist, or do you take students at Alpine?
we
Um,
do, and I
yeah,
think that.
yeah. So, maybe,
So a
how might you
couple of
start?
these, I'll try to answer your question, but
Yeah,
I want to say we take students, and we have a very elaborate like mentorship program for people we
awesome.
hire, often new grads. But and the walk-in model is great for that, right? Because they
Hmm.
can send us, like, I co-treat all the time. And so if they're having a tough patient, they can say, like, well, I'm going to be on vacation. You're going to go in and see this person at the walk-in clinic. I get a little step in. I get to see this person while, coverage for vacation. And I get to, like, tell this younger PT kind of my, like, everything here, but let's refine this a little bit. Let's work on this area. And so that's been really nice. And then we do have we have students all the time at Alpine. We don't They may spend a little bit of time in the walk-in, but they don't spend a ton of time in the walk-in. Um, but they are expected to, like, anybody that comes into any clinic, whether it's the walk-in or not, you're doing a whole eval. Like, somebody said this to me, maybe, well, what about a referral? What if the referral, are you still doing the same kind of evaluation? And I'm like, I rarely look at the referral. I mean, maybe if it's just like post-op and there's a protocol for sure, but I almost like to go in unbiased, even if says shoulder pain, I'm going to look at the back and I'm going to look at the hand. Like, I just don't trust. I have to, like, prove it to myself with all my tested measures, and, like, and that's where you start to own it. And I think, like, and sometimes you're wrong, and that's okay. And that's where we get to kind of come back, and every visit, like, I am, like, really retesting and making sure. And I, like, intervention, test, retest, like, intervention, test, retest. And so I think that this top of scope and as we talk about primary care, first contact, urgent cares, like, it should make people a little nervous because it's bringing up our caliber, it's elevating it, and it's like, you're doing the hard work in school, and you should step into that, and it's going to be uncomfortable, but guess what? That's okay. Like, that's how we get better, is being uncomfortable and sometimes wrong. But it's okay to ask questions. Like, I've called my primary care physician friends. I've called my sports medicine friends, and, like, I called radiologists and, like, hey, what do you think? I'm not sure here. And so, um, yeah, I think that we do need to to have that expectation of our education needs to match our practice. And
Yeah.
that's, I think, a little bit of a disconnect right now,
No,
is what I see is folks getting really great educations, and then they're becoming techs, basically.
Mm,
Like,
yeah.
yeah,
they're being told what to
interesting.
do.
Mhm.
And that makes my heart so sad, because the best thing we get to do is eval.
I'd like to differentiate. This is like one of my own beliefs that when we say top of scope, I get to practice at the top of my scope. Scope does not mean expertise. Those are different constructs, right? So
Mm,
scope is defined legally, right? Scope
yes.
is what you can do as a PT.
Yes.
And we are all trained to do all the things we can do, right? So we can take vitals, we can do medical assessments of, like, when a referral is needed. We can do our PT functional assessments and find things that we can treat, right? So there's all these things that we can do. In some states, we can order imaging, right? In some settings, like if you're in the military, you can pretty quickly learn to order a limited set of pharmaceuticals. That's scope. Expertise is something different. Expertise is like how you function within that scope. And so I think that's one of the things I think about, and I agree with you that when students come out, they have all the things they need, right? But we need to get them expertise in utilizing the full scope.
Yeah.
Yeah, interesting. And I think it also depends on the sort of the locus of what your clinical interest and focus is. Because coming from like neuro PT, vestibular PT, right? Like we do so much differential diagnosis as part of our day to day because the script almost always, the referral always like dizziness, right? And it's like, okay,
Yeah.
great. Let me see. Or it says VPPV, and then you read and no testing has been done, and you're like, okay, great. So it like this is something that's very common to like go through and then figure out like, okay, let me coordinate the care and figure out what's next. Yes, like, I can treat this. It is a peripheral vestibular condition, or no, it's not. This is what I recommend. So it's interesting. I think depending on the setting that you're in too, you might get really shoved into a lot more development of expertise and practice at the top of your scope. So yeah, it's interesting.
Yeah, and I think that there's like that's what's kind of really exciting about primary care PT. If someone is going to choose to find the expertise so they can practice at the top of their scope, with a combination of what they're getting in their doctorate level physical therapy degree, and maybe they need to seek out an employer or clinical that really pushes them in so that they can have a really clear pathway on what they feel really as an expert in. And expertise comes with practice, of course,
Yeah.
and just years also. But also, there's so many different options out there for kind of something from a tune-up, which is kind of what I did. I kind of have found these things along the way. Like I think I'm doing everything I can. Is there anything I'm missing? So I took the primary care certification that APT has on their learning center. It was like 6 modules. There was definitely some pearls in there. I was like, oh, I love that. I didn't think about it that way. And that's actually how I found the primary care summit, or the primary care SIG, was I attended the primary care summit. And there was like, those were my people. And just also with Montana, a lot of the APTA Montana, we tend to host a lot of courses that kind of focus around some of those areas too. So I think, there's a there's a lot of like wherever you are on that expertise level, there's a lot of opportunity to kind of fill the gaps as you feel like you need. But I think you do need to eventually get in the pool and like see what it's like to try to swim.
Yeah, I personally had an interesting experience with that because I took a job in the Army as a contractor. And so you're going in, and the first thing I needed to get credentialed at the hospital. And so they gave me this big packet of paperwork, and I'm filling it out. And I get to this section like, oh, yeah, I can order imaging. And I'm like, but I've never done that. I don't know how to do that. And then the pharmaceuticals, you can order pharmaceuticals. I'm like, I don't know how to do that. And so I called up the chief and I was like, hey, what do I put on these boxes? He goes, oh, mark that you know how to do it. And I was like, but I don't. And he's like, well, we'll teach you. We'll teach you. So, okay. So I come in first day, and I'll never forget. It was like the second patient I saw. I'd been working for like an hour and a half, and they wanted a refill on a pharmaceutical. And I'm like, oh my God, panic moment, right? Because I'm like, am I going to kill this person? Like, I think they wanted more ibuprofen. Right. But I'm like, oh, they could have a bleed. Like, what do I do? Like, you know what I mean? It was like, oh my God. But the mentorship of, having the senior therapist there that I could go over and, be like, hey, how would you respond to this? Right. And just ask a simple, quick question, go back, and all good. Right. And within, a few months, I was functioning at this new expanded scope, because they helped me gain that expertise through that like careful mentorship, which was really
Yeah.
nice. And I guess that's what I worry about this field is that we're our own bottleneck because we don't have enough clinical training opportunities to train people to like rapidly advance this.
Yeah. Um, and I think that there's probably some like clinic environments that don't support that either, and I think that you can get into a rut of
Yeah.
like just accepting like whatever's given to you and do the protocol X, Y, and Z. And you lose that part of what you spent, 7, 8 years developing as going through PT school. Um, yeah, I think it's
I did work in
interesting.
a clinical practice one time. There was 40 different PTs in this practice, and there was one blood pressure cuff.
Yeah. Wow.
Yeah, right? So, like,
Oh
they're not
boy.
doing it. They're not doing
Oh
it.
Yeah.
boy. Yeah.
Yeah.
And
Yeah.
one thing you said earlier, Sam, you mentioned the concept of, and this I keep thinking about what is primary care, right? And so when I think of like my PCP, right, I in general, I'm often not necessarily looking for it's nice when there's a like discrete, concrete answer to my problem, but sometimes I'm just looking for, get me the next step, order the test, help connect me with the next person. And that's something I think we already kind of do and can do well, right? And you'd mentioned when in doubt, refer out. So I think when we talk about in the differential diagnosis class that I teach, your job sometimes is to just figure out, am I the person to treat this thing, or am I going to refer? Can I refer and treat? Can I, like, what you're kind of putting together these pieces. And I feel like that's the part that um, maybe our critics need to recognize is we're not trying to solve all the things. Like, I don't want to see you if you have a cold or if you have shingles. I don't want to see you if you have
Yeah.
shingles. I want
Yeah.
to see you like, for something else. I want to see you if you're like, have some dizziness when you sat up and it's room spinning. Like, yeah, I want to see that. So it's, yeah, but it's just really interesting. I think when we think about like, what is the job of a primary care provider, and we are equipped to potentially do that from the get-go. So
Well, and I think that there's a lot of like, as a primary care PT, like you can work side to side in a clinic, in a healthcare system like the VA or a hospital setting, and be like one of those folks that are going to step in if it's needed, if that person, and go and do the consult. I think there's like, if you Google like top 3 diagnosis people seek out primary care for, it's top one is like, your common cold, second's low back pain or spine pain, and the third is skin conditions. Like we can really offload the primary care providers, and I think that's really important as we have these conversations. Like, let me see the hurt and the pain, and you then can open your schedule to dive deeper into that other and that people need. And I mean, we have wait lists. I mean, my mom said she had to wait 6 months to get established with her PT or her primary care doctor. Like, it's crazy. So we have a shortage of primary care physicians, just, that are very like knowledgeable of the entire body, entire system. So if we can kind of help with this like one lane, why not? And, I think just I think of like occasionally I do have like, I had this gentleman, and a lot of what we see, one of the other drivers was, in the community, we're very involved in the community. And we always get these folks like, hey, can you look at this? And how can I stop in? And we kind of start treating our, and we'd add people onto our schedule. And it's like, we would be really nice to have this walk-in clinic. And now I just give them the walk-in number and they call. But um, a gentleman came to me because his wife was my son's, soccer manager. We've been becoming friends and whatnot. And she said, I'm making my husband come see you. He has the number. He's made a schedule online with your walk in. And I was like, okay, sure. He comes in, and like his history, right? He's had a lumbar fusion, he's had a cervical fusion, and he like is a CPA, and he's just ramping up the season. He's been doing, and he's a partner. So he's like a lot of stress. There was something else that he had been doing, and maybe he had just gotten done with a bunch of travel, but he had weakness in his right hand, his dominant hand, to the point where he was having a hard time just with like hygiene and getting dressed and tying a shoe. And this guy's like muscle man, right? And so I kind of take the history, and yeah, he had the fusion, and he had gone straight to the orthopedic urgent care where he saw a PA. And he had had 2 MRIs, one of his neck, one of his shoulder. And it's been 6 weeks now, and he is like can hardly grab a fork now. He's really kind of concerned. He has good motion in his neck and all the things. I start to kind of go down the list, and he said, and then in the midst of this, he's like, "Well, they're gonna order a third MRI of my brachial plexus." And I was like, "Okay." I'm like, "Has anyone done an EMG study with you?" No, no mention of that. In his subjective, he'd had vaccines for like maybe 6 weeks prior to when I saw him,
Oh,
and that was like a little thing. I just kind of noted it. Anyways, his strength was like 50% reduced compared to his left. With the dynamometer, I asked him if he had, if it's the person he saw knew that it was that weak. And he's like, well, he just had me grip his fingers. And I was like, oh, we did treatment and we improved his grip strength by like almost 15 pounds just in one
Hmm.
session. So I was like, okay. And then after that visit, like, his neuroscience were definitely diminished, but didn't line up, right? Like things aren't lining up. He's got great range of motion, even though he has a fusion. I can't reproduce any of his symptoms. So I referred him for an EMG. It turns out he had Parson and Turner syndrome,
oh
which is
wow.
an infection after vaccinations, and it had happened very distal, where the branches of the median nerve, demyelination. Treatment is PT and conservative treatment and strengthening. So it was, and I didn't actually go back to the ortho. I just spoke directly to the EMG physician and said, I have this person. He said, absolutely. I'll get him in today at 5 after work. Got him in, got the results. And he said, good catch. So like, that is like where it's just fun. Like when things don't line up, that's even more fun. But like, you know, it's just interesting, right? Like he had been circling the system for 6 weeks and he had a lot of pain because he thought he was going to have another fusion. And just trying to calm him down with a lot of those kind of things was really great too. So a little story of like who I see and like how you
Yeah.
triage and
Thanks for that.
Yeah. And it's a
That
great example of like ruling in, ruling out, right? You were figuring out does this match the pattern that I'm expecting? Okay, no, it doesn't. And so this is prompting me to do something. It's prompting a referral. And it also speaks to the fact that the relationship building piece that I'm sure you've put a ton of time into, Sam, like getting connected with some of the other providers that you can speak with the guy who's going to do the EMG, right? And kind of building these relationships so that you are showing, yeah, hey, I am that provider that can catch these things and can kind of take on that responsibility. That's
well,
awesome.
and I had never had a conversation with that EMG physician
Mhm.
before, but and I think Katie O'Bright talks a lot about this, but like talking about like maybe in the military, Eric, you kind of were trained to do this, the SBAR, where you kind of situation background assessment recommendations. And so it kind of like it helps me kind of put on kind of a good script. So I'm not going tangent into the weeds like sometimes PTs can. And I can really kind of have this medical conversation with somebody that I might be intimidated by, but I know that I need to have this conversation. And so that script really helps me convey what I'm seeing and the concerns and my recommendations. And those are kind of some of the maybe what people might find if they do seek like a Con Ed here or there or want to sit for the certification or the board certification. Um, yeah. So
Yeah, it was interesting. You mentioned the military and the communication. There was the most fascinating dynamic that happened there. So many of the PTs that were functioning in that department, they're captains or majors or above rank, and the vast majority of who we interacted with were residents. It was a teaching hospital, and so the orthopedic residents were lieutenants, and so the PTs outranked the ortho residents, which served to like negate this like you listen to me kind of thing. Um,
Hierarchical sort
yeah, and
of
if it ever started,
thing.
the colonel would come in and be like, "Hey," and then the ortho residents would scatter. So anyway, there was this equality, this collegiality that happened, and it was really fascinating. And that collegiality allowed me to learn how to communicate like that because that intimidation thing was gone a little bit, and so you could just have good conversations. And maybe that intimidation comes from things in the community. I mean, I've certainly had in the community the opposite experience, but maybe some of it's our internal insecurity about not getting trained how to communicate that way, or not, I don't know. It's interesting. But it really, you make me think when you bring up that thing about how to communicate to people in primary care, because I think that's probably a big part of it.
Yeah, I think, like a lot of things, if you can have the one thing, right? The one thing is like, is this person getting what they need and in a reasonable time given their presentation? And it's all about the patient. And I don't think you can ever be looked poorly upon if you are truly like, have concern. And if they can tell you that that's not a concern, then that's great. But I don't think that they're going to judge you for that. And I do think like it'll be interesting. I'm working with our EMR health records right now, prompt, and just trying to like really have better follow-up with the patient. So I always send kind of a summary of their initial eval, and just basically it has like what we did, their home exercise program, expectations, just similar like what you do if you go to the doctor. They send a summary of the visit. And I
Yeah.
think that that's really nice to have. And then it also is documented that what if the patient hasn't seen anyone else, there is
Yeah.
documentation that I communicated with that patient if they don't end up coming back. And that's a role and
Sure.
responsibility that I am stepping into. Um, and I think along those lines too, what has really changed and opened up being able to do urgent care, especially towards the end of this deductible year, everybody hit their deductible. They all want to come in for PT, November and December. And like, I've seen up to 6, maybe 7 evals back to back.
Wow.
And like, you talk to some PTs and they're just like, oh my gosh, I can't even do 3 in a day. But the scribe has really helped. And, they're getting so good, and you can train the scribe to really understand and prompt it and put templates in there so it can listen for the information that you're talking, and it can streamline it so that you can do a lot of evals and not have the paperwork that is so dreaded.
Right.
And you get to do the fun part of it.
Yeah. So, as if we rewind our conversation, you said an important thing, and I want to make sure we talk about this because it's kind of exciting. You mentioned that you discovered the federal section and the primary care SIG through the summit that you went to.
Yeah.
Talk to me about that. What is that?
So the Primary Care Summit, Primary Care Physical Therapy Summit and Think Tank is, I think, in its 4th or 5th year. And it has exponentially grown every year. It's like almost doubled or tripled its size. And this, they're taking submissions for proposals to present. So if you're interested in presenting, we can offer that link up. And then we are going to be in Salt Lake this year in September 18th and 19th. And the course, or I think the way the conference is set up, the event, is there's like several breakout sessions that are, some are kind of spicy topics. Some are clinical skills courses. Then there's a couple larger where everyone is in attendance listening. There's some TED Talks, which, or I guess they're not TED Talk. They're kind of like TED Talks, or kind of talking
Yeah.
about a
They're
certain
like, if we didn't name it
element.
a TED Talk, it would be like a TED Talk, but it's really
Yes,
like,
exactly. I like,
we're going to call it a speak for 5 minutes passionately talk. Yeah.
Yeah. So it's really fun. It's small enough that you are really engaged, and it's such a diverse group of people. Like I said, it's growing where there's military, private practice, home health, education. We're seeing it all. Tech is there. So it's a really fun, and just so stimulating group of people to be around. And we're having it in Utah because Utah just did pass their primary care bill. They're recognized in the insurance law now as primary care providers. So, and we saw just last week, or they're still doing it. Idaho's in the midst of that right now. Montana, we will be updating our Practice Act to just modernize that to make sure that we have that language in ours in 2027. So we're seeing a lot of it. And I think, we've heard from lots of folks just recognizing that in the field, right? We saw this with imaging where it was like kind of like trickle, like 1 or 2 states, and then pretty soon it was 5 or 6, and then it's kind of just snowballs. So it's really exciting to see that. And I'm hoping that people can come out and attend the Utah event. Um, and yeah, we're still looking for sponsors. And you guys will be there, so we're
We'll
excited to
be
have
there.
you.
Yes. So
Yeah.
excited
Yes.
to
Yeah. So
come.
Yeah.
yeah. So,
Yeah.
you know, if PT Outcast listeners know or don't know, Carly and I have a company, Brainsmith, and we're in the middle of preparing a really, I think, engaging primary care certificate program. And
Mhm.
so we felt this real synergy with this summit and the event, and you know we've watched it grow over the years, and so we've come on as one of the main presenting sponsors. So we'll be really excited to be there and to learn and to engage in all of that activity, and hopefully, you know, it's another little like catalyst in this, you know, expanding opportunity for PTs to learn about primary care and urgent care. Like that's, I mean, that's really, really fascinating stuff. But
Yeah.
also fascinating stuff that we've been doing forever, right? We've been doing it forever. But
I want us to be able to tell the consumer, like that's the like
Yeah.
I want to make
Yeah.
sure that people understand, like we are doing it, but we're so bad at like making it more complicated than it needs to be, or like confusing, like, oh, it's same day service, or I can get you in quick. Like, call it what it is, so the consumer, because we are in a pivotal place in our society, I think, right now, healthcare wise, where people have these huge deductibles. They're paying a lot of money, and they're starting to become like, well, I'm going to be very particular where I'm going to spend this money and who I'm going to see. I want to see somebody that's going to get me in the right place right away. And so if they know how to get into PT, and then they can get into PT fast, if there's a big visual that says you can get in here fast, that helps the consumer. And then the consumer starts to drive it, right? They start to ask their payers or their insurance companies, well, do you guys cover, you know, urgent care PT visits? That I don't know, what is that? You know, like
Yeah.
the public loves us, right? Like very rarely do you go into and someone's like, oh, I hate PTs. Like people really like us. And I think, like, you know, we need our consumers to really step up to the plate and start talking to their insurance companies, start talking to their HR and say, like, this is valuable and I want you to pay for some of this. And we will not be able to do preventative care under the Obama or like ACA until we are designated as a primary care. We're specialists.
yeah,
And so that is pretty important legislation. If we are going to truly be able to treat the lifespan and have people come in throughout their life for their motor movement health, like a primary care physician would, we need to have that recognition at that legislative level. And then also, like, if we have a primary care recognition, people aren't paying their specialty copays, where
right,
it can
right.
be
It
up to
reduces by half
$95 a visit.
sometimes.
And then
Yeah,
that's cost
Yeah.
prohibitive for somebody to come in
Right.
to see us. So there's lots of reasons why we need to pivot. And, you know, I would even say, like, why nurse practitioners and private physicians assistants can be part of a primary care coalition. Why aren't PTs part of that primary care coalition? Like we
yeah,
have to like get out of our silo, get out of our complexity, and make it simple and like play what the structure is out there, so the consumer can help us with it, and we can help the consumer.
yeah. We need to respond to the need that society is presenting in front of us, right? So
Yeah, the
yeah.
one like fun update. So I would this is teaser for maybe
Hmm.
September. I don't know. This government is slow. Emily Hernan and I submitted for it's the Rural Transformation Health Program. It was $50 billion that went out to all the states, and each state had to submit how they're going to, you know, spend the money to help innovate Medicaid. And so Emily and I created this request for information proposal where we incentivized 25 clinics around Montana and over a course of 3 years. And we would come in and teach those clinics how to basically open up hours for Medicaid for urgent care, because we know Medicaid, you know, those folks are often working jobs that you don't dictate your own schedule. You have sometimes poor transportation or limited transportation. You're often taking care of somebody else, or have many different multi-family social things going on. So it's no wonder they're the highest cancel rates, and
Yeah.
they they are the people that need PT the most, right? Like,
Yeah.
and even just like management of chronic diseases and access to us. So we thought, like, why not write this grant so that each of these 25 clinics would then open up 10 hours a week for Medicaid walk-in urgent care, right? And so then
Fascinating.
that would also, in these rural towns, offload the primary care doctors who are needing to see diabetics and all the other infections and the stuff that they need to manage. We can be the first point of contact for the, MSK, movement health, those kind of things. So, and then the grant, because would also then track outcomes, and technology would be inputted to that. And so it was, a substantial $17.2 million ask. But if you're looking at what Montana got, which I think we ended up with like $2.4 billion, or maybe even more than that, we were fourth overall. We'll see if we will get that request to go and implement that program. It's still,
Ooh, that would
we
be so
haven't gotten a
cool.
firm no, but it will be really exciting if we have some of those opportunities in Montana. We also had 14 other states that submitted that proposal to their state. So we have, I like to fish. So we're putting our hooks out there, and we're going to see if PTs can step into this urgent and scale it, right? Like this is all what I'm talking about. We have to scale it. So part of me getting on this and talking to people about it is like, we all have to kind of move forward. And this was one way that if it does go, we could really scale it, and it would be pretty incredible. So I hope I have update in another 6 months for you guys on that front.
Yeah.
That could be exciting.
Stay tuned, waiting with bated breath here, Sam. This is amazing.
If you get that, we're having another podcast. We're having a bigger party about it. Yeah. So, all right. So listen, this was a fantastic conversation. I really appreciated learning about it. I think there's more to learn from you. I want to congratulate you for being on the forefront, innovating with your business and your clinic and your perseverance. Like, it took 7-8 years and a pandemic and all these things, right? But you're doing it, and you're doing a fantastic job. So it was a real pleasure to speak with you on the podcast today. Thank you.
Well, thank you. And like all things, like, I have some wings, but it is all the wind beneath my wings, man. I am so lucky to have so many people in my circles that are just like continuing to make things go along, and it's always gradual until all of a sudden. And it's folks like you being out there helping us bring this up and getting people talking and getting people excited about it. So hopefully we'll see a lot of people showing up at Utah next fall and continuing the conversation.
All right, great. So thanks so much again for coming on. Carly, as always, it's a pleasure. And Sam, real gem today. And we'll talk to you soon. Thanks for another episode of PT Outcast.
Thank you.